While Howard gets the slides up, I would like to echo what everybody else was saying, that Leukemia Research Foundation is one of numerous organizations that's patient-focused. They are one of the unique organizations that actually fundraises for cancer research. They provide funds for up to 10 to 12 new investigators all over the world. We're actually meeting in a couple of weeks to go over this year's grant applications, and hopefully we'll award another 10 to 12 grants. Some of these grants over the years have gone to folks that have sterling careers in cancer research and the leukemias and lymphomas, and it's been gratifying to see some of these investigators get started through the efforts of the Leukemia Research Foundation. So kudos to them. They also provide, as you know, support for patients and families as well as educational events. And their fundraising is something that happens all year round, including their 5K, the Gibbons 5K, which is coming up in June. It's always on my clinic day, so I have a ready excuse for not participating. So I'm going to talk to you about immune therapies for hematologic malignancies, and I think the genesis of this comes from the notion that you've heard when we see a leukemia, there's so many different types that we now are getting agents for 10% of patients or 5% of patients or 30% of patients, but what about the rest of them? And so we want to take a step back and say, is there something that would work for 100% of the patients, not just for the targeted patients for whom we have defects that we can potentially come up with new agents? And I think immunotherapy holds the promise of doing that. So the goal of this talk is to kind of update you on some of the immune therapies we're working with in the hematologic malignancies. So in order to invoke your immune system, which actually is the system that helps prevent and then control many cancers, you need a target. And cancer cells have unique targets, and they have targets that are very similar to normal cells. This target is called an antigen. It's usually on the surface of the cell. Antigens can be targeted by antibodies, as you've heard, things like rituximab, or some antibody conjugates, including the BiTE antibodies, or by cells, or in fact by both simultaneously. And we're going to talk about several of those. In cancer, the immune system does not respond appropriately to the presence of these tumor antigens or these cell surface molecules that are on the tumor cells. And I guess some of us feel that based on the number of cells that are produced in our body, you make 4 billion white cells every day, that some of these cells are actually leukemia cells, but our immune system is capable of knocking them off, taking care of those cells and allowing us to live our lives leukemia-free. But in patients that develop leukemia, these cells develop, and despite the fact that they are abnormal, our immune system doesn't see them as abnormal and therefore doesn't eliminate them. They grow in our bodies. How do we know that? Because sometimes when we put an intact immune cell into the body, it will actually kill the tumor cells. So cells that are functionally able, that are not yours necessarily, are able to kill the cancer cell, actually are associated with improvement in survival. So no response to these antigens means no cancer cell killing, and in fact, cancer cell growth. So the use of immune therapy, or this approach, is not new. In fact, bone marrow transplants, we didn't know it back in the 1970s. We just thought that we'd blast people with radiation and chemotherapy and put donor cells in and hope the donor cells didn't wreak havoc with the patient and lead to their death. What we found out over the many years by pioneering work done in the Seattle bone marrow transplant program is that it's actually the donor immune cells that are actually providing much of the heavy lifting. So if you have two patients with leukemia and one has a sibling that's matched, and the other has a sibling who's an identical twin who's matched, of course, the person who has the matched sibling that's not an identical twin has a different immune system, and that patient, if they had a transplant, had a lower chance of having the leukemia come back versus an identical twin with an identical immune system. So your immune system and your identical twin's immune system is the same, and if yours didn't recognize the cancer cell, your twins wouldn't either. Then we started working on, well, how much of a benefit is this fact in transplantation? And we actually, over the many years, reduced the intensity of the transplants and still see a great benefit And that's part of the reason we're able to do these types of transplants in older patients. The other the other therapies of immune system are antibodies. Rituximab was approved in 1997. It targets an antigen seen on both normal and abnormal B cells, CD20. Brentuximab is an antibody drug conjugate that targets CD30, which is seen on T cell lymphomas and in Hodgkin's disease. The third area is vaccines, and we know that HPV can cause cervical cancer. It's the cause of 90+% of cases of cervical cancer. It can cause head and neck cancer, and it can cause cancer of the anal genital region. And we know that vaccines, if they develop an anti-HPV antibody, can prevent those cancers. And Gardasil, which of course is the vaccine that young ladies should take before puberty, actually prevents cervical cancer. It doesn't just prevent HPV, it prevents cervical cancer. Hepatitis B, hepatitis C, we don't have a vaccine for C yet, but we do have hepatitis B vaccine, and that targets viral antigens, and hepatitis B can cause liver cancer. The newer areas are the dendritic cell-based vaccines, which we're going to talk about them. The dendritic cells are cells that are needed to bring the tumor antigens back into the picture, and these are frequently deficient in patients with cancer. And what you do is you make these cells and then put the tumor antigens on the surface and then jam them into the lymph nodes. Engineered T cells, which we're going to talk about in a minute, which target specific cancer antigens. And then finally the CAR T cells, which are actually chimeric antigen receptor, designed to provide receptors to the T cells that actually target a specific antigen on tumor cells. So immune therapy is widely used. And again, for CAR T cells, et cetera, we don't care what the chromosomes are. We don't care what the malignant genetic profile is. We're working on the cell surface. And fortunately, the cell surface heterogeneity is a lot less than it is inside the cell. So for cancer, the cells that we talk about most are the T cells. And T cells are used to kill and prevent virus infections. The T cells were the cells that were attacked by HIV, and so the people that got AIDS or HIV infection, the drug destroyed their T cells, preventing them from having a normal immune system, and those patients died of virus infections or other infections in which T cells are important, such as parasitic infections, or in fact, many of those early on got cancers that were unique to patients with HIV positive disease. You knock out the T cells, you're knocking out a cancer fighting and virus fighting cell. So your immune system is actually an organ in your body, and these T cells float all over the place. The tonsils, when you get a sore throat, get big, the adenoids, the lymph nodes in the neck, and we'll come back to that in a minute. The thymus actually educates the T cells that are initiated in the bone marrow. The spleen does as well, and again, lymph nodes are seen all over the body, the neck, under the arms, the groin, the spleen. Some of us consider a big lymph node. The Peyer's patches in the intestines and in the appendix, and even, again, these cells are found in your bone marrow. The lymph nodes, which are the small things you get in your neck that are tender when you get a sore throat, are basically the factory that generates the T cells. Blood goes into these and educates the T cells that are in the lymph node itself, and then the T cells are primed to say, I have a virus coming in. The virus floats around into the lymph node. You develop an antigenic response, and the T cells march out of the lymph vessel and into the tissues and help kill the virus. So T cells can kill cancer. We just mentioned that. It happens in bone marrow transplantation. And the first step is the antigen recognition. So we mentioned that tumor cells have cell surface molecules called antigens. And what happens in many cancers is that your immune system doesn't recognize your antigen. So the antigen recognition is absent. And again, one of the therapies we're going to talk about is educating your body to those antigen. Well, again, presume that under normal circumstances, an antigen like a virus or a cancer cell comes into the body. And as you can see there in the middle, there we go, the antigen is taken up to the T cells. The T cells then are primed, if you will. These are immature, and then they grow into activated T cells. Hopefully they'll disappear in a second. And then the T cells then march back into where the tumor cells are or the virus is, and actually then kills the tumor cell or the virus. The immune cells, however, are not just T cells, but are B cells, which form many of the acute leukemias of lymphoid origin, and for non-Hodgkin's lymphoma are also very important, and those cells can become malignant as well. So you have, if you will, on the top here, let me just show this doesn't work right. On the top here, the cell-mediated immunity, that's the T cells. And your body also produces antibodies. So when you get a cold or a virus, you not only get T cells that help kill the virus, you get antibodies that help kill the virus as well. And you get attacked by circulating antibodies as well as the physical attack by the T cells. Now, what happens when you get a virus is the T cells and the B cells go to work and kill the virus. Now, those T cells just don't vanish. They kill the virus, and there is another type of cell called a suppressor T cell that actually slow down those. Otherwise, we'd have T cells growing all over our bodies our entire life, and we'd have huge lymph nodes rather than lymph nodes that go back to normal. And these suppressor cells turn off the immune response. So once the target antigen is destroyed, you have T cells that turn off the immune response. But in many cancers, again, these suppressor cells are activated even though the cancer cells are present. So in other words, I have a cancer, I'm not producing normal T cells to kill it. In fact, I have suppressor T cells that are telling my killing T cells, hey, you're not needed here, we're in charge, and we're going to suppress any effects so that our cancer can grow and take over your body. So the use of immune therapy to fight cancer is not new. We talked about this. Transplant effectiveness, now that we know, is largely related to the new immune cells from the donor killing the leukemia or lymphoma or other abnormal stem cells. Unfortunately, this is, as we talked about before, a double-edged sword. It can kill the leukemia, it can kill the lymphoma. It also produces a condition called graft versus host disease, which fortunately only occurs in a minority of patients, but also unfortunately can be lethal. While we're working on new therapies and there are existing therapies that help control that, that is one of the major downsides of undergoing a bone marrow transplant, and something that everybody needs to take into consideration, both the physicians and the team as well as the patient and the family. But however, it is, again, the mainstay of effectiveness of the bone marrow transplant. Once we knew this, we said, okay, well, can we get these T cells or get these donor cells to kill leukemia without doing a transplant? And that's where we again went and started looking at saying, what's wrong with a cancer patient in their immunity? And then come up with vaccines, gene-modified T cells, and then the chimeric antigen receptor cells that you heard just a little bit about with Dr. Rodriguez. So here's what happens normally with chemotherapy for acute leukemias, lymphomas, MDS, or what have you. So a patient has a disease, and the disease are the pink cells on the left there. You still have a few normal cells. And so the pink cells take over your body, and these poor cells at the bottom here, let me show you these. These poor cells here are actually activated T cells that are trying to kill the leukemia cells, and here one of them finally got killed, but the majority of the cells keep growing. Now when you do chemotherapy, the chemotherapy kills a lot of the leukemia cells, and the blue cells again are the normal cells, but there's still a few leukemia cells that are left behind. And what we hope happens in the majority of cases is that your immune cells, because we're getting rid of this huge antigenic load, the immune cells will kind of reactivate and kill some of the cells. But as you know, leukemia very frequently goes into remission with chemotherapy, but is not cured, largely because the immune cells still leave a few tumor cells around. And these tumor cells then, over a period of time, can grow back. Transplant therapy puts in new donor cells. These donor T cells are more active, and they take out the original and remaining leukemia cells. So this is a patient here in this D profile here. These patients are cured because you don't see any more pink living cells. The T cells are now from the donor because the recipient or the patient's own T cells are not capable of killing the cells. So can immunotherapy, or can we replace bone marrow transplant? And the notion is that certain leukemias, as you heard about, are cured with chemotherapy. One of them is called NPM1 mutated leukemia. And we give the patient chemotherapy. There's still a few leukemia cells left, and our own immune system is capable of taking out those cells. So some leukemias are cured, and we think this is what happens likely in pediatric ALL, in which the cure rates are 90% without transplant. But unfortunately, as you've heard, the majority of patients undergo therapy and they are not able to get rid of all these leukemia cells. And the question is then, can post-remission immunotherapy, other than a bone marrow transplant, take out the rest of these cells? Now, as we mentioned, the targets for immunotherapy are on the cell surface. We don't have to worry about the specific gene abnormalities. And there are viral antigens, there are peptides, there are proto-oncogene peptides, cancer testis antigens, minor histocompatibility antigens, and there are other things that are seen in tumor cells on the cell surface. And these are products of genomic instability or peptides that have been identified by analysis of looking at these cells. We can develop then antibodies to these tumor cells. We can develop T-cell receptor antibodies or other proteins that are capable of killing these cells, which are then taken by antibodies. So Rituxan and brentuximab are antibodies that will target these cells, or cells themselves when you don't have an easily identified target. So we're going to talk about the main areas. There are other areas that people are working on, but the two main areas for leukemia, using your own cells to beef them up, so to speak, are dendritic cells and engineered T cells, and we'll talk about both of the types of engineered T cells. Now, dendritic cell vaccines, we talked about when you get a virus or you get a cancer cell, the tumor cell has an antigen on the cell surface, and this is recognized as being abnormal. What happens in these cells float around and they need to get into the lymph nodes to educate the T cells to kill them. And that is basically a cell that's carrying the antigen to the lymph node, and that's called a dendritic cell. Now, dendritic cells start out as blood monocytes. We have these in our blood tests. If you get a CBC, you get lymphocytes and granulocytes, but you also get monocytes. And what we can do there, and these dendritic cells are defective in cancer patients, what we can do then is juice these suckers up and have them help kill cancer cells. And we do that in several steps. Number one, we take the monocytes and make them into immature dendritic cells. And that's done in a laboratory, in a special laboratory, cGMP facility. And then once we have these cells to a certain level, we then mix them either with tumor cells themselves or tumor cell lysates or specific antigens that can be put on these dendritic cells, or antigen encoding RNA, make these cells then into cells that have on their cell surface the antigen. These then are injected into or carried in the bloodstream to the lymph nodes, where they are re-educating the lymphocytes, your own lymphocytes. These develop antibodies, they develop T cells, they develop NK cells, and then these are capable, hopefully, of killing the cells with the tumor antigens on your body. So just educating and finding a way to get the bad part of your cancer cell into the lymph node and have the normal T cells do the job may be a way of getting your cancer cell killed. This has been done in a variety of diseases. It's effective. There are modifications that can be done to make it more effective. This is a paper we participated in. This was just published this week using a dendritic cell-based vaccine for telomerase, which is seen in many of our normal cells. And what we did was we made an antibody, we made a dendritic cell to focus on telomerase. So what happened is we got patients into complete remission here, AML and CR, and then took blood cells, the monocytes from the blood cells, and then gave the cells to a laboratory, which then made dendritic cells and then functioned as a dendritic cell against telomerase. Patients were given vaccinations, and if they continued to do well, they took a period of time. It's kind of like getting a tetanus shot, if you will, over time. And then boost vaccinations were done over time, and we looked at what happened to the patients as well as what happened to the immune system. So this was a typical patient population that went into complete remission, and the remission had to have quality that you proved that the patient was truly in remission. They were eligible if they were in first remission or second remission. They had to be in remission very quickly, and they were excluded, however, if they were likely to be cured with just the chemotherapy. Cutting to the chase, we would expect in patients in complete remission above the age of 60 to have a survival of only about 20% at 5 years. And so here's the patients, here's at 4 years. This is where we would expect the survival curves to have come down, and in fact, it was about a 60 to 65% survival, and it didn't matter whether you were young or old and had a bad leukemia. So it's a proof of principle. There are very few patients in this trial. We don't know if this is going to go forward with the company, but again, as a proof of principle, dendritic cells can be re-educated and can help fight your cancer cells, residual cancer cells, and these patients did not get a bone marrow transplant. The second thing that we're going to talk about is engineering the T cells themselves. In other words, forget about the dendritic cells, but let's make T cells that can actually help kill your immune system. And there's two forms of this. The first are called the T cell or TCR or T cell receptor products. And what we do is we take your normal T cells, again, we collect them from the bloodstream, and we have a virus that carries a specific T cell receptor into the virus, which then makes the T cell receptor, and the T cell receptor floats to the surface of the cell. So we have actually an ongoing protocol for a malignant melanoma, and we have a melanoma antigen that we then put on the cell surface of these T cells. The melanoma antigen then goes to the immune system. These cells target the cancer molecules at or below the cell surface when attacked and kill the cancer cells. And these preliminarily are effective for malignant melanoma, and they're being tested in a variety of other diseases. The nice thing about this therapy is that pretty much if your tumor cell has a specific receptor on it, these cells will kill. We can make them for everybody. The downside is that these are very cumbersome to make, they're very expensive, and it takes a long period of time and a lot of reagents to get to where you need to go. However, again, for tumors like melanoma, like kidney cancer, and potentially like acute myeloid leukemia, these cells, again, could produce a nice response with a lot less toxicity than the CAR T cells and be universally available. The others are the chimeric antigen receptor, or the CAR cells, or the CAR T cells, and these are the ones that are in the news and likely to be FDA approved within the next 4 to 5 months. Again, the same type of philosophy. We have a virus, and it carries not the T cell receptor into the tumor cells, but it carries the codes for an antibody binding site that then floats to the cell surface, and this recognizes normal antigens on your tumor cells. The one that everybody uses is called CD19. CD19 is seen on non-Hodgkin's lymphoma, it's seen on ALL, and it's seen on CLL. These are cells that are grown in culture and then infused into patients with advanced disease. These target the molecules on your tumor cells, and when infused can, as Dr. Rodriguez mentioned, produce remissions. So the CAR Ts in the middle here have an anti-CD19 chimeric antigen receptor on their cell surface, and then the cancer cells, which has a CD19, they attach and then are capable of breaking apart or killing the cells. So here's what happens. Again, a patient has peripheral blood collected for genetic manipulation. And again, we're using these for ALL, and patients can have active ALL. You can have leukemia in the blood and still get these T cells out. The T cells are gene modified and then are grown in culture and then infused back into the patient. These are effective in acute lymphoid leukemia, non-Hodgkin's lymphoma, and chronic lymphocytic leukemia. And we're going to talk about the BALLs, or the B cell, the CD19 positive ALL, and here's some data. As you can see here, these are refractory disease patients, and the outcome, 91% complete remission, which means that patients came into the therapy with active leukemia, got one infusion of these cells, and 91% of them went into remission. Here's one, a 90%, the NCI, a 70%, and Seattle, 83%. Now these cells are not without toxicity, and in fact, rarely patients have had severe toxicities, and a couple patients have died in these studies. But these again are patients in whom all therapy pretty much has failed. Refractory, relapse refractory. When we see R with a /R, that means relapse and refractory. These patients have failed other therapies, and in fact, some of the patients have even failed the bone marrow transplant. Yet 91% of the patients go into remission, and some of these patients' remissions have lasted for a few years. The toxicities are CRS and neurotoxicity, cytokine release syndrome. When you put these cells into a milieu of all sorts of cancer cells, the cancer cells die and release chemicals or stimulate an immune response that actually helps kill the cells, but also causes blood pressure drops, allergic reactions, and can cause CNS toxicity, including what we call encephalopathies. Very few of the patients do succumb to these, but again, that has happened rarely. But again, in a situation that we constantly face in bone marrow transplant, we have therapy that may cure you. We have therapy that does have some downsides, and you might die from it. But ultimately, the chances of you being alive and surviving your cancer, all things taken into consideration, including the possibility of death, the survival is still better than the other options available to you. So we participated, as was mentioned, in CAR T-cell from Kite, which licensed out the technology from the National Cancer Institute. This is a CD19 specific CAR T-cells. We again collected cells from our patients. They were enriched at the laboratory. They were activated with an antibody viral vector for the CAR gene CD19. They expanded these cells, grew them in culture, made many copies of them. They froze them and then shipped the product ready to send and infuse into the patient. This is a 6 to 8 day process, and again, the patients are then given a little bit of chemotherapy to suppress their immune cells so these cells have room to grow. Early on, there are 32 patients in this study, of which 29 had come to a point where they could be evaluated. And again, these are lymphoma patients. Overall response rate, you can see here in the middle, is 76% with a complete remission rate of 40%. These are patients with large cell lymphoma predominantly that have failed other therapies, including transplantation. To see a complete disappearance of disease with any other therapy is just unheard of. We never see response in a complete remission. So this is truly striking results for patients. And here you can see here on this PET scan here, these are lighting up. Holes in this big glob here in the liver, as well as other areas, are completely gone after transplantation. These black spots here before therapy are part of a positive PET scan, and these again are completely gone. And this was a patient with large cell lymphoma who failed a transplant, who got one infusion of the CAR Ts and went into complete remission. So this is for ALL. Again, as you can see here, the remissions last 78% for these ALL patients at periods up to 2 to 3 years, and so survival again 51%, and these are phenomenal results considering how refractory these patients are. This is updated data as of February. This is actually going to be presented in more detail at the upcoming cancer meeting here in Chicago in a few weeks. Overall response rate for 77 large cell patients, 82%. 49% had complete disappearance of disease, and a third of these patients were still in complete remission at 6 months. Again, something that we would just not see with any other therapy. So it's kind of exciting therapy. It's relatively toxic, and again, I've already elucidated that. Here you can see the waterfall plot. This, as it hits down here to 100%, this is the percentage of patients that had a complete disappearance, and it's very uncommon to see growth. Most patients have a nice response, some of them not complete, and if you don't have a complete response, you'll likely grow. We think that those patients potentially should receive a second dose. That's not been done yet, but overall, again, response rates in the 75% range with long-term remissions at 6 months of 35%. Here just shows a lymph node adenopathy. You can see here this cake, if you will, over the spine here is all cancer cells. And here is a patient 2 years after infusion. Here, all the cake is gone, completely gone. These patients are still in ongoing complete remission. These cells cannot be found in the bone marrow. When we look for the cells, this is a patient who got CAR Ts for CLL. It lives in the bone marrow, and as you can see here, literally at 5 weeks, the leukemia is gone from the bone marrow. And again, here shows that these are abnormal cells and they're totally gone. These are the positive cells initially, and then you can't see any of these cells in the bone marrow. This is not really being explored very extensively for CLL, and I think largely because of what you heard from Dr. Venugopal. We have pills that will do the same. But for relapsed ALL, for relapsed large cell lymphoma, we don't have therapy that's as effective as this. So what I tried to do again is to give you kind of a sense of where we are right now. We're kind of in the infancy of this, although we've been working on immunotherapy for hematologic malignancies for quite a long period of time. We've identified that an allogeneic or donor bone marrow transplant is largely effective because we give immunotherapy. Attempts at duplicating this immune effect in a non-transplanting setting are showing promising results in a variety of hematologic malignancies. It's likely that the first licensed products for ALL and non-Hodgkin's lymphoma will be available later in 2017. These are going to be expensive. They are individualized patient therapies, but they are independent of the genetic abnormalities that we see in the patients. They're likely to be significant costs, and there are significant toxicities, so you won't be able to get these at your local community hospital because of the severe toxicities that are being seen in some patients. You do need an ICU. You do need transplant-type physicians that are capable of modulating or modifying these, and you need your cardiologists and pulmonologists to help manage patients who temporarily have severe toxicities. But again, effective, yes. Very effective, yes. Surprisingly effective, yes. We don't know what's going to happen at 2 or 3 years, but these are treatments that truly are on the edge of producing great remissions in a large number of patients. We'll still keep working on the genetic profiles of patients and come up with new drugs. And as I mentioned, these were first tested in CLL. We don't use them in CLL because we got new drugs. We would like not to have to use these down the line if we can come up with a pill that's going to be just as effective. So let's finish there. And again, I'd like to thank everybody for coming and participation. We'll have a bit of a break for about 10 to 15 minutes. Kevin's coming up and we'll give you some instructions. And then all of us will sit up front and you can barrage us with questions and stories and advise us what's happening in your minds and in your family's minds. Thank you.